Assalamu alaikum. I am Dr. Nida Khan, Year 4 resident at Dow University Hospital, DIMC, in the Department of ENT and Head and Neck Surgery. Today I am going to present a very unusual case of a 17-year-old male who is resident of Quetta and he has no known comorbids. He presented to outpatient department with a complaint of nasal obstruction for 7 years. Body discharged from nose for 5 years and loss of consciousness on and off for 5 years. His nasal obstruction was right-sided, abrupt in onset, progressively increasing and was complete. Nasal discharge was from the right nostril. It was watery and clear, intermittent, and was pronounced on bending forward. It was not blood-tinged, not foul-smelling, and he experienced a drop, 1 to 2 drops per 2 to 3 hourly a day. Associated symptoms include loss of consciousness episode for 1 to 2 hours. There were a total of 4 episodes. In the last episode, he also had fever, for which he was conservatively managed at a tertiary care center. There was also generalized weakness. There was no association with sneezing, nasal pain, loss of smell, blurring of vision, epiphora, fever, weight loss, and headache. He had a history of trauma to nose in childhood when he was 9 years old. And when he was 13 years old, he went for a nasal surgery and the record was unavailable. Drug history was not significant and there was no history of chronic illness and malignant diseases in the family. On examination, he is a young male with average build and height, well oriented in time, place, and person. His vitals and subvitals were within the normal range. On examination of nose, external, there is a prominent broad bridge. Nasal asymmetry is prominent towards the left side. Hypertelorism is present. On palpation, there was no tenderness or crepitus. We did a naso-endoscopic examination in our outpatient department, which showed a reddish mass in right nasal cavity on naso-endoscopy. It was non-tender and was attached to the septum on probing. There was DNS towards the left side and patency was decreased bilaterally. There was no increase in the size of mass with strainous activity. Rest of the examination was unremarkable and there were no neurological deficits. So we made a few differential diagnoses, starting with adrophonal polyp, encephalocele, glioma, schwannoma, teratomas, meningoencephalocele, and in the last is common cell carcinoma. After the routine hematological and biochemical investigations, we went for 2 specific investigations, which were CT cystonogram scan of nose and PNS with contrast, and MRI head and brain with contrast. These are the pictures of coronal view CT scan contrast, showing defect identified in the right anterior cribriform plate, which is approximately 8 millimeters in size. There is a protrusion of fluid-filled polypoidal sac through this opening into the point sinus and nasal cavity, which is closely abutting the middle and inferior turbinates with displacement. These are the axial views, showing DNS towards contralateral side, subtle isodensity identified within the sac, and focally protruding gliotic brain parenchyma. CSF cystonogram shows tracking of CSF fluid within the sac. However, no dribbling was identified in the current examination. The impression was of right-sided frontoesophageal encephalocele identified with tracking of CSF fluid within the sac. These are coronal views of TT to T1 weighted MRI images showing defect in the cribriform plate on the right side, associated with herniation of fluid containing meningeal outpouching from right anterior inferior frontal region into right nasal cavity, approximately 4.1 into 3 into 2.5 centimeters. These are MRI T2 weighted coronal images showing CSF signals on all sequences with few internal septations and dependent hyperintensities on fair sequence. Overall findings represent defect in right-sided cribriform plate associated with meningocele in right nasal cavity. So after the investigations, we narrowed down the differentials. We narrowed down the differentials into three, being meningoencephalocele on the top, teratoma, and glioma. After the general anesthesia fitness, we decided to plan for endoscopic removal of mass with navigation, of course with neurosurgical backup. Now we are setting the navigation system here. Probably we are the only center operating navigation FES here. The mass was attached to the septum with adhesions medially. As you can see in this video, this is the mass, and it's attached to the septum, most likely due to childhood trauma or nasal surgery. We decided to separate the mass from the adhesions with bipolar diaphragm carefully, and then we dissected with blunt scissors. Here you can see the defect superiorly as we have mobilized the mass. After mobilizing the mass, the defect can be seen clearly, and we decided to clear the pedicle, both cranial body, and transfix the mass. After transfixing, we remove the mass. With bipolar diaphragm again. After removing the mass, we put the remaining pedicle in the defect. Then we decided to perform septoplasty as there was gross DNS towards the left side. And we took septal cartilage as a graft to fill the defect. You can see visible pulsations there. The septal cartilage is there, but the pulsations are still there. We then decided to take middle truncated pedicle graft. And now we are placing the middle terminate pedicle graft on the defect after the cartilage. After that, we applied a layer of Surgicel. Here you can see the pulsations are completely stopped. In the end, we placed fibrin glue on the top. Bilaterally splits were placed in both the nostrils, and sponge stone nasal packing was done. This is the picture of the mass excised. It was approximately 4 into 2 centimeters and was sent for histopathology. This is a picture of patient post-operatively, first day. There were no post-op complications and the patient was discharged the very next day. To our surprise, the histopath came out to be mature teratoma. And no immature component was seen. We decided to take a second opinion and we sent the specimen to another center and they also said that the biopsy is consistent with mature teratoma. This is, the patient came after 1 month for follow-up and he was symptom-free and was very happy. We did a nasoendoscopic examination and as you can see, the graft has been taken and there is no defect. After 1 month. Teratomas are rare developmental tumors comprising elements of all 3 germ layers, including ectoderm, endoderm, and mesoderm. Teratomas of head and neck are exceedingly rare, usually present in the neonatal period, which is less than 2%, with an incidence estimated from 1 in 35,000 to 1 in 200,000 live births. Most of these cases are found in the cervical and nasopharynx. Clinically, the incidence of teratoma decreases with age. A slight female predominance is present. The head and neck region, including the upper respiratory tract, is a rare location for such tumors in both children and adults. Only a few cases have been reported in available literature. Germ cell tumors in general are classified into germinomas and non-germinomas. Germinomas present approximately 2/3 of intracranial germ cell tumors, while non-germinomas include embryonal carcinoma, choriocarcinoma, and teratomas. They represent 0.5% of all intracranial tumors. Intracranial germ cell tumors arise almost exclusively in the midline locations. In most cases, these tumors are located specifically in the sellar and pineal areas. Biochemical markers such as serum alpha-fetoprotein and beta-HCG can be useful in differentiating teratomas from other intracranial neoplasms. If AFP is elevated, it is strongly indicative of malignant teratoma. Which feature? आगे. बस. Mature teratomas in anterior fossa located are extremely rare and of benign characters. Teratomas can be benign or malignant on the basis of mature and immature element. Mature teratoma are always benign. They are composed of well-differentiated derivatives of 2 or 3 germ cell layers. They can be removed surgically. They can be solid, cystic, and mixed. On the other hand, immature teratoma are always malignant. They resemble embryonic elements, most commonly nervous system components, bone, cartilage, mucinous fluid, hair. They are rapidly growing and they are predominantly solid. The condition is very rare. The mature teratomas are benign and usually radioresistant. Only treatment is surgical excision. Mature teratomas have been reported to have a survival rate of 93% in 10 years. However, a phenomenon of tumor recurrence has been reported, known as growing teratoma syndrome. Now, what is growing teratoma syndrome? In this syndrome, the recurrent tumor is presumed to be refractory to chemotherapy or radiotherapy. Take-home message is consider teratoma as a differential diagnosis of masses in the nasal cavity, and middle turbinate pedicle graft has a good uptake. Thank you.